I'm Thomas Baldrick. We are happy to have with us here at ASH 2015 Dr. Naval Daver from the MD Anderson Cancer Center. Thank you, sir, for joining us again.
Thank you.
Let's
Happy
talk
to be
about your passion, AML. You've got a study of combination of Vosaroxin and Decitabine in newly diagnosed older patients with AML and MDS. Let's talk first about the unique challenges of treating these older AML patients.
Yep, absolutely. I think in hematology and leukemia, this has been one of the most difficult groups of patients historically for us to have any improvement in survival and response rates. For the last at least 15 years, there have been a lot of concerted efforts towards improving the outcome in older AML. And to put it in perspective, in the younger AML patients, our most recent data shows that the overall survival for somebody below 60 with new diagnosed AML is about 60%, which has gone up from 30% 10 years ago. So there's a doubling, and you were doing well, the combinations are improving, we're using molecular therapy. However, in the older AML, our data shows that it was 10% about 15, 20 years ago, the 5-year survival, and today it's about 15 to 20%. So still a lot of room for improvement in that group. What we have seen is the hypomethylators have had some improvement for sure, and they are the backbone of treatment of elderly AML as single agents. They definitely improve symptoms and blood counts, and also have shown to have improvement in survival in 2 large studies that were done, one in Europe and one here in the United States with decitabine, and similarly in 2 large studies with azacitidine. So I think it's definitely a start, but what we have now been trying to do for the last about 5 years is to see how we can improve on the hypomethylators, either the decitabine, azacitidine. And in leukemia, historically, combinations have been the way to go. ALL was improved significantly with hyper-CVAD combination. It revolutionized the treatment. And now, we're trying to see what is the ideal combination. And I have to say, it's been difficult. We've gone through many different combinations. We've combined Vidasa with Revlimid. We've combined decitabine with Valproate, decitabine with a CD33 antibody, gemtuzumab. All of them had some hint of improvement in specific subsets, but none of them really seemed to be a big home run that would be valid to go to a phase 3 trial. Now that's changing in this last 1.5 year. I think we have at least 2, maybe 3 contenders that are looking very promising. One is the abstract that we have here. The Vosaroxin was initially done in a big 711 patient phase 3 study in AML for first relapse, Vosaroxin with high-dose Ara-C versus high-dose Ara-C. It was the largest study that's ever done in AML, led by Farhad Ravandi from our department. And it showed there was clear improvement in survival, especially in patients who are above 60, as well as in patients who could not go to transplant. And right now there's discussion both in Europe and in the FDA in the United States to see if it could be approved in both places or one of them, and we're very interested in that. But building on that, since we saw this improvement specifically in the older patients, we said, well, maybe we can now move this from a salvage, which was the previous study, to a front line, and of course combined with hypomethylators, which are already the standard approved agents. And so that's how we ended up with this study, and the results are very promising. We're seeing response rates of 75%. These are complete remissions and complete remission with incomplete recovery, which is double of what we get with single agent decitabine. It's usually 30 to 35%. The other 2 drugs that are very interesting is ABT199, which is a BCL2 inhibitor, and Dr. Courtney DiNardo from our department is doing that study. And that one also shows exactly the same response rate, 75% CR/CRi, also well tolerated. And so I think these 2 drugs are both extremely exciting, very similar in their response rate, and we need more time to see how this overall survival matures. And I think these could be both going into phase 3s in the next, hopefully, 2 years or so. And a third one that's on the horizon, a little bit earlier in development, but it is exciting, is a monoclonal antibody called SGN33A. And that one, in combination with decitabine, also is showing good results. Will be presented today, actually, by Dr. Fatih. So these 3 studies, we're hoping at least 1 or maybe even 2 or 3 of them will be able to move forward for elderly and really make a dent in this difficult scenario.
So when we leave this ASH 2015 conference, you feel like we'll be entering a sweet spot for treatment of AML.
Right.
Why is that?
I think we're entering the beginning of the beginning of a revolution is what we feel, and I think a lot of it really has to go to understanding the biology of AML. Compared to the last 40 years, in the last 5 years, because of the molecular revolution, now because of the understanding of the microenvironment and its effects, and because of the immune phenomena, which is the newest kid on the block and could be very important not only for solid tumors and lymphoma but in AML. We are now understanding that single agent treatment doesn't work. Molecular therapy is good, but alone cannot hold AML. It's a dynamic disease, unlike lung and breast and colon. So if you inhibit one mutation, it escapes through another. So you need to combine the molecular with something else. And the tumor microenvironment or stroma may play equal or a very large role in the tumor propagation. So now we have drugs that can target individually or in combination these different pathways. And I think the IDH and FLT3 inhibitor story is moving along nicely. They've all gone now into combinations with standard agents and with novel agents. We're actually doing some novel agent combinations with FLT3 inhibitors and CXCR4 to do a molecular plus stromal manipulation. There's some with standard Vidasa and IA. So I just think that there's a lot of interest now in moving beyond 3+7, Vidasa and Decitabine, which for 15-20 years where we were stuck. And we're already seeing early phase 1-2 improvements, and I think we're going to be moving forward. I think the biggest study here that is clearly should be going to approval is the Ratify study, which was a phase 3 of FLT3 inhibitor PKC with 3+7 versus 3+7 alone, showing significant improvement. It did take 10 years, long study, but I think that could be the first approval for AML, hopefully this year, in almost the last 15-20 years. And hopefully after that we'll have many more that are coming.
And this is a message you want to get out to community physicians.
Yes, I think that's the important message, is that historically AML people have just kind of given up to a little extent and thought 3+7 Decitabine, if it doesn't work, that's it. I think that's changed a lot. Now we have a lot of molecular targets, immune targets. We can actually personalize therapy. I know people talk about personalized therapy and it seems like this dream, but today we're really there. At Anderson itself and at other big centers, we have monoclonal antibodies to CD33, CD56, CD123, CD25. We've got molecular targets to IDH1, IDH2, FLT3. We're now developing immune targets. This is the newest thing in AML, to PD-L1. We're looking at PD-1. So every patient, when we get them, we can probably pick the 1 or 2 markers that are best for them, even though they're seen each one in about 10-15%, and personalized treatment. I think that's really going to change things. So if you have patients, at least consider, talking to your local academic center, see what they have, go to clinicaltrials.gov. And a lot of times we see the patient, put them on something and send them back to the community physician so we can co-manage. And that way everybody wins. And on trials, the drugs are free a lot of time, so it could be beneficial to the trials, to the academic centers, and to the community physicians, and most importantly to the patients.
Absolutely.
Yeah.
Thank you, sir, for sharing your data, your knowledge,
Absolutely.
and your excitement.
Thank you very
Appreciate
much.
it.
Yeah.